Course. Doing that. Hello there. Hello. Students joining? No one? Bakri, Ladun, Abir. Nobody saying yes?
Hello.
Yes.
Hello, how you are? That's good. Say hello, Tariq. Tariq Hashim.
Yeah. Hello, doctor.
How are you? You batch 26?
Yes.
Okay. Well, let us start. Bismillah ar-Rahman ar-Rahim. This is the fifth lecture on the series of lectures on tropical medicine. I do enjoy giving you these lectures, and I hope you enjoy it too, because tropical medicine is not taught in all universities to the extent that it's to its importance. So I'm delighted to be here with you, and I would like to take you through filariasis. What is lymphatic filariasis? And we have already indicated in the previous lectures when we dealt with onchocerciasis that this is a filarial infection, a filarial nematodes. Uh, but the word filariasis is coined to by the common people and by some doctors to refer to lymphatic filariasis, although it's not the only filarial disease, but that is the coin of the when the people talk about filarial disease, they may refer to lymphatic filariasis. But scientifically, filaria is a nematode, as we have said last time. It's a rounded worm, and we have seen that nematodes are very prevalent in Earth, in animals, in humans, and in humans it's gastrointestinal, like ascaris, in animals. But we have to differentiate between intestinal helminthiasis, which is worms, and tissue worms. The, here we are talking about filaria disease, filariasis, which is a tissue worm. In onchocerciasis, we have seen that the microfilaria lives in the skin and the nodule in subcutaneous tissue, and somehow they don't go beyond the subcutaneous tissue of the human. As to why this is characteristic of that nematode, and God knows why it is restricting itself to that region. We have to differentiate between infection and morbidity. Infection and morbidity. Morbidity is disease. We see patients in the clinic, at the level of the clinic, at the level of hospital. These are disease patients. These are moribund patients by an infection. Okay, but infection generally doesn't mean disease because you may harbor the infection for quite a long time without any sequelae, without any sequelae. However, from a public health point of view, this is extremely important because these people will act as a reservoir of the disease. So, for a clinician and internist who deals with patient in the clinic, when he cares about the patient, he gives him treatment and all the rest of it. And that we will deal with also. But for public health expert, he goes out beyond the hospital to the field. And here there are patients and there are infected patients, infected individuals, let us say infected individuals, and there are patients with symptoms. Okay, so the treatment for that particular part of the community has to encompass also those who are asymptomatic patients. What we say asymptomatic patients, this is logical because they harbor the disease in a sense. They are not well because they harbor the disease, but they're not showing a lot of manifestations or any manifestations. Uh, why? One may be that the disease is dependent on the dose of the microflaria or the worm. If they don't receive enough dose of that microflaria, they will not show illness. Okay. Secondly, most of the tropical diseases are dependent, their reaction, the disease is dependent on the immune response that the patient will counter. We have seen in onchocerciasis that the pathology is caused by the dead microflaria with an intense immunity. And in that disease, we have seen when your immunity is so strong that it localizes the disease to one part of your body, like an arm or a leg, as in Sudan, which is Aswad, or which is seen in Yemen and in North Sudan, Abu Hamad. So I would like you to make this distinction that patients can be ill because of the infection, but sometimes the infection is there. One of the characteristics of lymphatic filariasis, which is caused by, in 90% of cases, by the nematode called Wuchereria bancrofti. Wuchereria bancrofti. And Wuchereria is spelled Wuchereria, Wuchereria bancrofti. There is another nematode from the filarial or the lymphatic filariasis is Brugia malaya. Brugia, Brugia, Brugia malaya. And this is in Southeast Asia. Malaya is Malaysia, and this area is Southeast Asia. But this only causes 10% of the cases. So Wuchereria bancrofti is the main organism or nematode that cause lymphatic filariasis. We should introduce some terminology. Transmission. When we talk about transmission, this is the dynamic process whereby the disease continues its life cycle in a community. When we talk about elimination of the disease, we talk about interruption of transmission. And within the transmission, there is a cycle, a life cycle of a disease. And this life cycle is important epidemiological consideration when you want to interrupt transmission. Take schistosomiasis. Schistosomiasis is prevalent in Sudan, in many parts of Sudan, and in Jazeera. People or young people urinate and defecate near the canals, and then by doing so, they contaminate the water by their feces, which contains eggs of either hematobium or mansula. And then these eggs has to go into a snail to be developed. If these eggs are eaten or touch the human being, a healthy human being, they will not be affected. They need to have a cycle within the snail to mature these eggs into an infective form, which is the cercaria. So the snail will issue or get the cercaria, and the cercaria is like a sperm. It has a head and a tail, but these cercaria can penetrate healthy human skin. All right. The healthy human skin, the cercaria develops on and on and on till it becomes adult worm. Okay. And the adult worm produces eggs which pierces the colon or the bladder and then it secretes the eggs. And this is how the cycle continues. For a public health expert, for all doctors who think about eliminating diseases, is you have to interrupt this transmission. So knowledge about how the transmission cycle, how the transmission health is concerned, you have to break the cycle at one weak point. And this weak point may be the snail, if you have facilities to clean the canals, or it may be the disease patients. You don't kill the disease patients, but you clear the infection from the clean patients, or you prevent healthy people from wading and swimming in the infected water. So this is the sort of a cycle. I'm giving you just an example of a schistosomiasis because many of you would know this cycle. So breaking the transmission, breaking the cycle, it's it's a concern of multidisciplinary. One, the clinician who is treating the individual patients. This is okay. The entomologist who is an expert in vectors or insects that transmit diseases. Okay, in epidemiologist who knows how to manipulate villages, how to get people into collaboration, how to educate people, and the rest of it. The other part is the parasitologists. Parasitologists are those concerned about the worms, their character, their weakness, their healthy life and their unhealthy life. So they study the life of the parasite so that they can pick up a weak point where it can be attacked either by a chemical or a drug. So these are the parasitologists who care about parasites. So it's a discipline, it's a multidisciplinary approach which need to be studied carefully. Uh, some of the parasites are, as we said, with the onchocerciasis, Wolbachia, the bacteria, endosymbiotic with Onchocerca volvulus. And this is a discovery which is not, which is recent, and this has actually broadened our understanding of how to attack Onchocerca volvulus. So this is a discovery, which this is what the parasitologist should do: find areas where we can attack that parasite in a good sense. So since we have people who are infected but not diseased, this will constitute a challenge because they don't present to the hospital, they don't present to the clinic, they don't complain. So their motivation to take drugs is not very high, like a patient. And so they constitute a reservoir, a very difficult reservoir. Lymphatic filariasis, which is caused by Wuchereria bancrofti, or in other words, elephantiasis, the fayular region, elephantiasis, is a disease need to be chronic in infection. So if you have an attack by 2, 3 times injection of microfilariae, you don't get elephantiasis, you don't get filarial lymphatic filariasis. So you have to have, if you are in endemic areas, you have to be there for quite a time and get infected from childhood to adult life. This is how you get the infection. If we just take the figures from WHO, they reckon that there are 88 million people infected with وشريرة bankruptcy of lymphatic filariasis. But only 20 million of them are showing disease. So the majority, almost 75% of the people are infected but not diseased. So this is very important to consider. And when we talk about the second definition is mass chemotherapy. Okay, this is directed towards the disease and the reservoir. And mass chemotherapy is where you have an infection of a certain level, maybe meso, which is moderate, to high, which is hyper. You treat everybody. And we treat everybody here because of that consideration, because of some people who have the disease, but they don't show, as they have the infection, but not the disease. This is what we call mass chemotherapy. And this is one of the most excellent advances in public health approach to elimination of tropical disease. So we go there in the village, we do a rapid epidemiological mapping, and for onchocerciasis, we feel the nodules just clinically. If you have a level of 40% or more, then you have to treat everybody, be him or she infected or non-infected. In lymphatic filariasis, the rapid epidemiological survey is examination of males for hydrocele, because Shariri bankruptcy has a predilection for the lymphatics of the testicles, epididymis, testicles, orchitis, and filling up the tunica vaginalis of the scrotum with fluid, which is called hydrocele. So this is a rapid method. We don't go and take blood for epidemiological mapping. In this case, we just do clinical nodules in onchocerciasis and testing or seeing patients' testicles to identify hydrocele. And you remember from your surgery, hydrocele is fluid with the tunica vaginalis, and this is can be clearly seen as the swelling of the testicles around it, but it has trans-illumination. So if you just put a torch on one side, you can see it because it is fluid. So this is mass chemotherapy depending on a rapid epidemiological index. And this is called preventive therapy or preventive chemotherapy. We talk about preventive chemotherapy. It is for disease and for non-infected, for non-disease patients, for infected individuals. So this is in books of public health, they call it preventive chemotherapy. And this has been shown with onchocerciasis and has excellent results. As I said last time, you give ivermectin once a year or twice a year for the lifespan of the onchocerca volvulus. And the lifespan of the onchocerca volvulus is about 15 years. So we continue for up to 15 years when the adult worm vanishes or dies by old age. So this is mass chemotherapy. And the beauty about it is the development of the drugs. The drugs 15 years ago, 20 years ago, were very toxic to treat tropical diseases. But nowadays, we have simple drugs orally given with little side effects, and they are being donated by big drug companies for free. So mass chemotherapy is now an answer for elimination of many diseases. The word control is control as a public health problem. We talk about a disease which is causing concern, public health problem. That is to say that it is affecting the health system, is draining the health finance, and it is causing absence from work and social problem. That is the concern as far as public health is concerned. That is one stage. So one stage is to decrease or make the disease no longer a health concern. That is, control the disease as a health problem. That's number one. The step two, when we are doing good, we go up to elimination of the disease. And elimination here is not talking about clinical as much as it is talking about parasite, presence of parasite in the body. Okay. So elimination is when we break the transmission to a non-viable transmission cycle, meaning that the infection is still in the community. Some patients are still in the community, but transmission has been interrupted. The level of the parasite in human body is so low that the vector, although it is there, but it cannot take the parasite to give it a cycle, give it a cycle. So it is being interrupted. Transmission is interrupted. And we could talk about local areas like Cameroon, like Mali, Senegal, where transmission has been interrupted in certain areas. That is localized breaking of the cycle. When we talk about eradication, the word eradication is a more strong way of elimination of the disease. Eradication meaning globally, worldwide, that the disease has vanished. And the only disease which vanished from the globe is the smallpox. So we are trying with guinea worm, like medinensis, Dracocurus medinensis, but it's not. It's still there, and there is a handicap in that campaign because suddenly we discover that it is a zoonotic disease. It is still harbored in animals, which are perpetuating the transmission. Okay, coming to lymphatic filariasis, this is, as we said, a disease of 88 million infected, 20 million diseased, and it is catastrophic in its full-blown clinical picture. It is really handicapping. Why? Because it involves the lymphatics, it involves the edema, continuous edema, very big body like legs, or huge scrotal hydrocele, or a huge arm. Breast can be affected, but legs, particularly unilateral legs, are the most affected organs in lymphatic filariasis. What happens? There is a vector, and the vector is a mosquito. The vector is the mosquito, and there are different mosquitoes like Culex, like Anopheles, like Aedes aegypti. Please remember that lymphatic filariasis is a disease of urban and rural pattern. Onchocerciasis is a disease of rural pattern, but lymphatic filariasis can exist in cities and in towns. So if you are living in a very high town, you could still harbor that because there are mosquitoes which are sewage water mosquitoes, as just like in Khartoum. You have the Culex, which is a bad mosquito. It has a painful bite, all right? So it can transmit the disease, the Culex, and it's usually in the sewage water, water Magari, or it can be in household utensils, which if you are keeping water for fear of cutting off the water supply, then you keep it in barrels, in uh, dishes or whatever. And if these are kept for a while in the open, then these type of mosquitoes, which are airborne type mosquitoes, can communicate. Just to remind you that there are four viruses which are transmitted by only for the viruses only, but others, like malaria, lymphatic filariasis, and others, I'm not talking about. These are the viruses which are transmitted by mosquitoes. One is yellow fever, which is endemic in western part of Sudan. It's a serious disease. Secondly, is chikungunya. And the name, although chikungunya has nothing to do with chicken, is a concussion. which now is prevalent in Gadaref right now at this moment, chikungunya. It doesn't cause death, but it can cause disability. Okay. Then we have Zika virus. Zika virus is relatively a new virus, which may not affect the adults except if they are ladies who are pregnant, because it affects the baby by producing teratogenicity of microcephaly. Zika virus is not a good virus, and it's a lethal virus for children. You get a microcephaly with maybe abortion or death, or even when the baby comes out, he's permanently handicapped. And then dengue fever, which is hemorrhagic fever. And nowadays, dengue fever is prevalent in the eastern part of Sudan, like Gadaref and Faisal. So this is about the vector of lymphatic filariasis. So uh, the mosquito is is a very funny creature. It's a very strong creature, and it transmits disease in a very efficient way. A very efficient way. I love to tell you about innovative and creative ideas in tropical medicine. Okay, an original brain is a brain which thinks straight and thinks about problems. Okay, so I would like you to have original brain. That is innovative brain which thinks in terms of research. Always question, why is this happening? Who is doing it? Why? Can I improve on it? This is the original brain. Don't take things for granted. If you recite my lecture today, tomorrow you can talk like me with all the informations that is good but not good enough. I would like you to take this lecture and analyze it, dissect it, and see where it went wrong, where it was insufficient, okay, to make better. If we can't make you better than us, we failed as teachers. So you have to be better than us. And you only be better if you are a critical mind person. That is research. I want to tell you a story. That is how the mosquito was discovered to be the vector. How the mosquito was discovered to be the vector. Okay, there is a person called Patrick Manson. Patrick Manson is one of the geniuses of tropical diseases. And you could remember him by remembering the intestinal form of schistosomiasis, which is called Schistosoma mansoni. Mansoni. He is the Manson who discovered that worm. I think he was dissecting bodies in Egypt when he discovered that there is a worm around the intestine, around the colon, which secretes eggs, and that was the mansoni, because the hematobium was discovered first, but he coined his name uh, the uh, to the mansoni. Okay, how he discovered the vector. And now, if I ask you what is the vector of lymphatic virus, it's mosquito. You never even think that there were times in history that nobody knew how the disease was transmitted. And this is very essential. If you want to control a disease, you have really to know the cycle, the transmission, and the vector. And what he did, this man in China, he was working in China, he saw that legs of elephantiasis or legs of lymphatic filariasis are common. He thought that there is a vector, there is a fly or a mosquito or what. He picked the mosquito as the possible vector. What did he do? He found a patient, his gardener, who had very big leg, elephantiasis, and he convinced him to sleep in a mosquito a room full of mosquitoes. He slept there. I'm sure he didn't sleep, but anyway, he spent the night there. Okay, and then next day he went out, but Manson came and collected the mosquitoes, because the proof of the pudding is in the eating. So if he finds the filaria in within then the mosquito is responsible of somehow transmitting the disease. What did he do? He said, I shall not, I'm reading his words, I shall not forget the first mosquito I dissected. I tore off its abdomen and succeeding in expressing the blood contained within the stomach. And then he placed that blood under the microscope. And then he said, wow, I was gratified so far, placing the under the microscope, I was gratified that I found the same organism which I found in the blood of that patient in the stomach of that mosquito. And the word gratified meaning satisfied with pleasure. Gratified. Meaning God have given me a present. Okay? Satisfied, gratified with pleasure. And then this is his writing. And then he said, it seemed that the acid which is in the stomach of that mosquito did not harm the filaria or did not harm the microfilariae. Very funny. On the contrary, he saw that the acid was stimulating its growth. And he saw a phenomenon. These worms have a sheath, okay, have a sheath. If you take it from blood and then look at it, you can have a sheath. And this sheath prevents the microfilariae from penetrating the blood vessel because it has to go through within the blood. But in the mosquito, this sheath has been stripped off, like somebody taking his garment away or his trousers away and become naked. The microfilariae became naked, ready to penetrate, and it penetrated the abdomen into the thorax. And then later he followed that one which ingested, then it was stripped, then it went into the thorax, and by the time it went to the thorax, it grew up multiple times, and it has a mouth and it has a gut. And this is what we call larva 3. Okay? Larva 1 is the one which is produced by the adult worm in the body, in the human body, issued and living in the bloodstream. That's larva 1. The mosquito will take larva 1 from the blood, and then changes occur like what Manson has described. Okay, during the process in the mosquito, it becomes larva 2, and then the robust larva 3, which can be injected into the human being who is not infected. So this is a beautiful critical thinking of Manson, and Manson has discovered other things. I'm sure we can talk about him. Okay, so the vector is the mosquito, which is known to you. The parasite is the Wuchereria bancrofti in 90% of cases, and this is a repeated infection. I repeat, repeated infections will result in elephantiasis or disease like elephantoid type of skin, elephantoid type, meaning that the skin becomes harsh, thick, keratotic, fissured, and folded. So that is the skin of a person who had lymphatic plexuses obstructed. And this is not peculiar to parasite because the adult parasite here blocks the lymphatic system, not the microfilariae. Please remember, it's not the microfilariae, it is the adult worm which blocks the lymphatic system. Okay, it has a predilection to the lymphatic system. I've always been curious about what attracts this parasite to the lymphatic system and attracts Onchocerca volvulus to the skin. You can think about that. Why is mosquito not transmitting oncocerca valvulus. It's only the simulium one. So there is peculiarity here. And this needs a lot of research and not of original mind. So if we go back, if a human being is injected by L3, L larva 3, then it goes in and seeks the lymphatics under the skin, seeks the lymphatics. You see, predilection, the lymphatics. And then through the lymphatics, they circulate to the nearest lymph node, be it the groin or the axilla. What do they do there? They stimulate hyperplasia of the lymph nodes, and the lymph nodes become swollen and slightly tender. But then they escape. They go out into the main trunk of the lymphatics, and they grow coming back into the lymph nodes and into the other lymphatics. And in the lymphatics, the adult worm lives in two forms, male and female. They are in permanent copulation. They are just hanging to each other in a copular stage, like they want to fertilize each other, or male female fertilization, almost constantly. The whole life of these worms are stuck together in permanent copulation, and they live up to 8 years before they die. All the 8 years, what they do is feed themselves and copulate and produce microflaria. And the microflaria has a predilection to the blood. So they go into the bloodstream. So the adult worm is the cause of the morbidity, unlike onchocerciasis, where the disease is caused by microflaria in the skin. Here it is the adult worm. Okay, the microflaria has a peculiar pattern in appearance. And this has been noted by Patrick Manson. He said the microflaria appears by sunset. It's totally absent or very absent. You cannot see it during the daytime. If you take blood for an infected patient, then you don't see it during the day. It starts coming at sunset, but it reaches maximum in midnight. It reaches maximum at midnight. This is why we recommend, if you want to see the filaria or diagnose filaria, you go midnight, wake up the patient and take blood and then do the test under the microscope and see the microflaria. But now we have better techniques for diagnosing. But that is the pattern of the microflaria being at night appears in the blood, and then the maximum is around about midnight, and then they go down. By the time it is sunrise, then they are so little. During the day, they're absent. Why? This is something which need to be studied. Maybe that if we change this pattern, we get cure. We get a disease, a drug which can give us cure. All right. The the adult worm is round about the female, like all nematodes, is longer than the male, 10 centimeters versus 4 of the poor male. The male is only 4 centimeters, again, is the long female. And maybe that God has ended this female with a lot of activities which need to perpetuate itself. All living organisms, their job is to survive. It's the job to survive. We do everything. We eat, we care about ourselves, we treat diseases because we want to live. This is similar to animals. They run away. The gazelle will run away from the lion because they don't want to be eaten. Okay, the parasite will flourish itself and keep itself by copulation and fertilization. So that is the worm in the body. So what does it do pathologically? Pathologically, it has a predilection to certain areas. Okay, it has a predilection to the inguinal nodes, axillary, and you can see commonly legs, okay, affected. You can see arms affected. You can see breast affected. And usually it is unilateral. You get it one side and you don't get it the other side. Okay, this is purely pathologically obstruction of lymph nodes, of lymph channels. Okay, what will happen is the worm will still stay there. It causes endothelium hyperplasia, okay, and infection. Infection, secondary infection, is always should be remembered in the pathology of lymphatic filariasis. When we talk about the skin, infection and reinfection, especially of the lymph nodes called adenolymphangiosis, can be repeated from time to time and cause a lot of harm, a lot of illness to the patient. So infection is there, endothelial hyperplasia, and then they have an infection there, and then they grow into granuloma, and the granuloma changes itself to scarring and becomes a scarred lymphatic vessel. Then it explodes. Whenever you have a scarred vessel, then you have an occlusion. What happens? If I scar the lymphatic here, all the draining lymphatics, okay, the retrograde, then it goes filling up that limb. And what will happen is that the lymphatics will break in the subcutaneous tissue, giving you edema. And the edema is classically non-pitting because the lymphatics, the lymph fluid is very rich in protein and in fat. So when it is eased, broken, rupture, and it goes in subcutaneous, it fills up the limb. It is non pitting. Then it grows. The leg grows, affecting the skin. The skin initially becomes shiny and thin, but then repeatedly it becomes dermatitis, keratotic, fissured, And the description, elephantiasis, if you see a leg of an elephant, this is typical of it. I have already sent you some summary of the lecture, and there are some pictures which you can see there. So it is huge. Lymphangitis or lymphatic filaria and lymphatic legs are not only restricted to the filarial disease. Because if you block the lymphatics of any limb, then you get a sort of elephantiasis. And this happens in the armpit. There is a surgeon who are fond of radical mastectomy, which is due to cancer, and it used to be the operation of choice. I think it's now going out of phase. This radical mastectomy, you take the breast, you take the lymph nodes around the breast, and you take the lymph nodes in the axilla for fear of that they harbor mitotic cells. So what will happen is the arm will be full of lymphs. It grows like corrugated skin and becomes blackish, and it becomes heavy, very heavy. Okay, looks like elephantiasis of the filarial infection. I have seen a patient, a relative, who had mastectomy, okay, in the maybe 79, radical mastectomy. That was the time when this operation was fashionable for cancer. She lived, but she developed very huge arm to the extent that she has to push the arm to move it. She cannot move by itself. And then later on, her children used to take the arm to put it on the other side for fear of sores. And at the end of the day, because so heavy, it affected her life, it has to be amputated. This is one cause of huge elephantiasis in non-filaria. And the other lymphatics affected is by silica. If people go barefooted in mines of silica, then they absorb silica, it blocks the lymph nodes and then they get sort of elephantiasis. I would like to remind you, if you have a wound in the foot, then the drains of the lymphatics in the groin, in the lymph nodes of the groin, then you get enlarged lymph nodes, then tender lymph nodes, you can get fever and chills. وده بنسميه بالعربي اشجدي اشجدي. بيقول لك ده اللي عنده الاشجدي اللي هو عنده جرح in the leg which has transmitted itself to the lymph nodes near the lymph nodes, which usually is the inguinal lymph node. So this is where the adult worm live in the lymphatics. It blocks the lymphatics and then result in a leg which is huge, which is rough, which is fissured with ulcers, with pain, and then you will have repeated infection. The repeated infection is called adenolymphangiosis, what is called ADL, adenolymphangiosis. Okay? And this is what worries the patient. He gets episode of adeno from lymph nodes, lymphangitis, inflammation of the nodes and the lymph vessels, and then they get fever, they become ill, they have to restrict their movements and so on. They be given drugs. One way, if we talk about treatment, one way of handling this infection is by constant cleaning of the leg, constantly, especially in the fishes, by soap and water, and we teach the patient how to do that. So by that, we reduce the rate of infection in the leg. And so this is one of the making life better for the patient. It's a very devastating disease, and if the breast is affected, you know how that will affect and impact the social and the psychological the psychology of the lady. It has a predilection to the genital, male genital, and they cause orchitis, epididymitis, and funicularis, and inflammation around the tunica, and they get hydrocele. Hydrocele is so common in endemic areas of lymphatic filariasis to the extent that the rapid epidemiological mapping is dependent on seeing a hydrocele in a male, an adult male. So if I take 50 adult male, I examine their testicles, then if there is hydrocele 1, 2, 3, 10 out of 50, then it is 10 out of 50. This is epidemiological mapping of the disease. So hydrocele is very common and it responds to saline. It responds to saline. So it's the important thing here is the symptomatology of the disease and how you make life of patients better by controlling the infection and treating the disease. Okay. Does it does it help giving specific treatment for filarial disease at this time? And the answer is no. Because once you get that stage, it is far gone. Okay, the adult worm has lived there, maybe died there, and the vessels has been really interrupted, scarred, and you can do little by giving the drug. The treatment is only symptomatic. Symptomatic. There are other manifestations which are not very common of this disease. You could have a lymphatics which will become after the scarring becomes tortuous, balloon, and varicose, and they rupture. In retroperitoneal lymphatics, then the kidney can be affected. You could have a fistula between one of the lymphatics and the pelvis, and then all the lymph which is stored goes into the pelvis and comes in the urine, what we call urea or lymphuria, meaning that there is lymph fluid coming in the urine, urea, and the lymph fluid is very rich in protein and fat. So the urine becomes pale like you are producing شوربة فيها fat وفيها protein. So the urine will be thick, whitish, and if it is blood, it becomes pinkish, and this is what we call child urea, which can happen if the lymphatics break into the pelvic, the kidney, or in the bladder, or in the bladder. So you can get funny presentations like this, and these are for surgical treatment. For surgical treatment. Okay, how would we, in the coming 10 minutes, how would you control the infection? So two stages. A stage in the patient, we have already highlighted, to give antibiotics to clear. And for the rest of mind, you could give a specific treatment for the filarial disease because it will not affect the affected limb. So if they have residue, it will just uh, prevent furthering of the disease. Okay, but the important aspect of lymphatic filariasis is the control in the community, the control of lymphatic filariasis in the community. And this is one of the diseases which really need to be community-based treatment by preventive chemotherapy. Okay, there are three diseases, maybe four, but three diseases which I reckon are the best for treatment of lymphatic filariasis, especially infected, not diseased. Infected, not diseased. So the disease, if we want a map where this should be applied, is sub-Saharan Africa, what we call tropical Africa, southeast, southeast Asia, okay, some parts of Latin America and South America, okay, and islands, the Pacific Islands, just north of Australia. These are the areas where lymphatic filariasis is very common. So if the endemicity is meso-endemic, you need to give mass treatment. And here mass treatment depends if there is onchocerciasis or there is no onchocerciasis. You remember one of the drugs which is very effective against onchocerciasis, which kills microfilariae in masses, but kills the microfilariae in the eyes, is diethylcarbamazine. And this we said last time, it's a blinding drug. So it kills the microfilariae, but loses the sight and the eyes of the patient. So this is a drug which is now completely contraindicated in areas where there is onchocerciasis. This drug, to my mind, is the best drug to kill lymphatic filariasis or Escherichia bankrofti. So diethylcarbamazine has a very good effect against microfilariae and maybe also against the other 12. So all combinations in non-onco area has to contain DEC, diethylcarbamazine. Okay. The second drug is albendazole. Albendazole. Albendazole is a drug for worms, intestinal worms. It's a beautiful drug. It's only given once in 400 milligrams, single dose. Okay, for a child, then you see the ascaris coming, out of the stools and almost dead. So it clears the intestinal wall. It's very good for intestinal wall albendazole. And this there are some effect on the other Escherichia bankrofti or lymphatic filariasis. And the third drug is ivermectin. You remember our wonder drug, okay? Campbell and Omura, who discovered it, who had Nobel Prize. This is ivermectin, which is given in a dose of 150 or 200 microgram per kilogram body weight. We can give these in combination. You can give this in combination. DEC, ivermectin. That's good. Or ivermectin and albendazole in onco area or endemic with onchocerciasis. Okay. So, and some areas where there is no onco, we can give all three drugs. And these drugs has to be given annually for patients for very long periods, more than 10 years, and it has shown effect. It has shown effect that the endemicity of lymphatic filariasis is now decreasing. And some areas are now free of the disease because of this mass chemotherapy, or what we call preventive chemotherapy. DEC is a drug which has side effects. It's called gastrointestinal effect because it kills the worm. It has some effect on the body. Prostration, fatigue, sometimes fever. But generally, it is acceptable. The beauty about the drug is that it is tasteless and it is stable in cooking. What am I driving at? I'm driving at making it salt and distributing it with table salt. Now, this is what is happening in India. I have visited India. I have seen how this is working. People will get the salt, put it on the ground, and add DEC powder, and then mix it, and then take it in the sacks and distribute it to the village. It's now part and parcel of the salt distributed in endemic areas in India. This is because it is tasteless. If it has a bitter taste, people will not accept it to put on the salt. The second thing is stable. So the drug is stable even if you cook with it, then it is stable, and it has shown this is a big dose, which is acceptable because there is very little side effects apart from the one we talked about in onco. The drug can be tolerated well, and now this has shown that there is tremendous reduction in the infective rate of lymphatic filariasis in India. Okay, the second mix is albendazole, as we see on it. Ivermectin is also another drug, and beautifully, these drugs are being given donated free by the company which produces, as long as it is needed to who need it, to as many as who need it, to as long as it is needed. So it's total commitment by these countries. If you really write up a good proposal for the country through the WHO, then this drug company can ship you. Even the shipping expenses are being paid by the company. So if you have these drugs, then the challenge will be how to deliver it. Because you are talking about communities, partly not ill, okay, but you have to convince them that they have an infection and get some people from the family who has the disease. You say, well, we don't want you to have that disease. You should swallow. Because most of the people say, well, I'm not diseased. Why don't you give it to my friend who has a disease? But this is what is the role of the public health expert, to convince people, help educate people about taking the drugs. And if you really manage it, then you get good results. And the way you manage it is get volunteers. We get volunteers who take the drug. We teach them how to give the drug. And usually these drugs are the single dose, like albendazole 400 milligrams single, or by ivermectin, which is a pole with height, and then by height, which is easy. You can even have a tree, just bar the tree and let somebody to stop against the tree. And if it comes here, it is 4 tablets. If it comes here, it is 2 tablets. So it is easy. So that is the challenge, distribution, and what we call coverage. If the coverage is above 70%, that is to say 70% of the population have the drug, then it is effective as a control measure of these infections. So this is filariasis. We have dealt with onchocerciasis, which is a filarial disease. Lymphatic filariasis is another disease. And then there is a filarial disease, which is in lower, it's in the blood, but it doesn't cause a lot of harm. I think I will talk to you about it because it has an interaction with ivermectin in patients with onchocerciasis. Okay, there is drunculus medinensis, which is the guinea, also a filarial disease, but the cycle is different, and then we can talk about it. So it's in summary, this is the disease caused by Wuchereria bancrofti, and it is prevalent in many areas. It can be controlled by mass chemotherapy, and a patient who develops it is stigmatized, handicapped by a heavyweight leg. Okay, the diagnosis is simple. If you go midnight, you can get a blood sample, deem the stain just like staining for malaria, and you can see the microfilariae. Okay, you have to wake up the patient, but can I do a trick to get the filaria in the blood without getting in the midnight? I can give a small dose of diethyl carbamazine, DEC. Okay, I can give a small dose, and then hey, microfilariae, okay, which comes in the blood, and then you can take the blood sample and get the microfilariae. That is DEC assisted, okay, test. But now there is a circulating filarial antigen, what we call CFA, circulating filarial antigen, and the antigen is detected by a monoclonal antibody using ELISA technique. But this is complex. It's a laboratory work. And if I need it to the field, I can get all these machines to the lab. But nowadays, a company has produced a CAR test, which encompasses all the mechanisms of this test. And it is called CAR test for lymphatic filariasis. All you do to take a blood, put it, and then you read it. If the patient is positive or negative. It is very good for quick diagnosis, for epidemiological surveys, and for identifying areas for treatment. So, in conclusion, this is a disease which is handicapping, which is uh, luckily we can eradicate it, or better term, we use control as a public health problem and eliminate it. And this will cover the second disease of filaria. Next time we talk about other filarial disease. Okay, and our respect to Patrick Manson, who discovered the vector of lymphatic filariasis and other vectors, which we are going to talk about. Thank you very much indeed. That's the end of this lecture.